Hello, welcome to our Health Matters webinar, The Rise of Medicare Advantage. I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today. Together we'll be talking about the surge in popularity of private Medicare Advantage plans, which now serve a third of all Medicare beneficiaries. While these highly popular plans offer benefits not covered by traditional Medicare, there are persistent questions about their higher costs and worries about quality of care, especially for sicker patients. And critics are concerned that their popularity heralds the privatization of America's public health safety net for seniors. What's at stake for seniors in your community? How can you tell good stories that will connect with your audiences? This webinar will help you get started on reporting on an essential story about a program that covers 60 million Americans across the country. We'll hear from three distinguished speakers. They include one of the country's leading experts on Medicare, Tricia Newman, Senior Vice President of the Kaiser Family Foundation, where she oversees the foundation's policy analysis and research on Medicare. We'll also hear from consumer advocate David Lipschutz, who is Associate Director of the Center for Medicare Advocacy in Washington, D.C., where he works on public policy issues surrounding Medicare and its beneficiaries, and leading journalist Mark Miller, a nationally recognized expert on trends in retirement and aging. Mark writes regularly for Reuters, the New York Times, and Morningstar. This webinar is offered thanks to the generous support of the National Institute for Healthcare Management Foundation and the Commonwealth Fund. You can tweet about the webinar at the hashtag Medicare. A word about our format today. You'll be hearing from our panelists first, and then we'll turn it over to our audience for questions. Because we have several hundred people on the call, we'll ask you to write your questions in the control panel of GoToWebinar. You can also write us there if you're experiencing any technical problems. We'll be archiving this webinar afterward at centerforhealthjournalism.org. Now let's turn to our speakers. Tricia, get us started with an overview of the essentials we need to know about Medicare and Medicare Advantage.
Great, thank you. Hi, Michelle, and hi, everybody who's listening. Thanks for inviting me here. I'm Tricia Newman. I'm with the Kaiser Family Foundation. And just for those of you who aren't familiar with us, we are a nonprofit, non-grant-making organization that focuses on national health issues. And we are a nonpartisan source of facts, analysis, and information. I'm really pleased to be talking about Medicare Advantage because it's such an important part of the Medicare program and growing. But before I do, I just want to back up because I know many of you are thinking about writing about what it means for people in the program. And in doing so, I want to just point out a few basics about the population we're talking about. Medicare is a diverse population, but half of all people have incomes of $26,000 or less per person. Many have functional impairments. Many are in fair poor health. And go to the bottom of this slide for a second. 20% have a cognitive and mental impairment. That's an important thing to remember as we start to think about Medicare looking more like a marketplace than it has in the past. So what is Medicare Advantage? Medicare Advantage is an alternative to traditional Medicare. Beneficiaries can choose to get their Medicare benefits and sometimes other benefits through entities known as HMOs and PPOs. There's an annual enrollment period. Medicare pays private insurers a fixed amount of money, a per capita payment with some adjustments, and also often provides plans of bonuses for the five-star quality-based stars that they have. Plans are required to cover all Medicare-covered services under Parts A and B, and most also cover the drug benefit under Part D, and most cover extra benefits, which I'll get into in a bit. Medicare Advantage enrollment has quadrupled over the past 15 years. If you just go back to 2005, you can see that 13% of all people on Medicare were in a Medicare Advantage plan. Now it's 34%. This is really a very dramatic change in what the program looks like today in comparison to what it looked like in the past. In the early years, Medicare Advantage or Medicare HMOs were just an option taken by a very small share of the population. This is clearly changing, and as I'll get to in a bit, all signs are pointing to rising enrollment in numbers and millions of people and as a share of the population in the future. What this means is that the role of private plans has taken on a much larger presence in the program than it has in previous years. So while 34% of all people overall are in Medicare Advantage plans today, you can see from this map that there's a fair amount of variation across the country. So with a national average of 34%, you can look down at Miami-Dade and see that 66% of all people in Miami-Dade, people on Medicare, are in a Medicare Advantage plan. But if you contrast that to what's going on in Anchorage, just less than 1% of people in Alaska are in a Medicare Advantage plan. Looking across, you can see Carson City's at 14%. But even if you focus on a single state, there's a lot of variation. So while with Miami-Dade, there's 66%. If you go to Jacksonville, Florida, it's more like 32%. Or if you go to Kansas, you can see that 40% of people in Kansas City are in a Medicare Advantage plan, but only 21% in Wichita. That means as you're thinking about what this means for people, the story is going to be very different depending on where it is you are in the country. That said, everywhere in the country, Medicare Advantage is ticking up. And as Medicare Advantage is ticking up, so too was the number of Medicare Advantage plans available to people on Medicare. What you can see here is the average Medicare beneficiary has a choice of 28 Medicare Advantage plans in 2020. This represents a steady increase over the past several years. More and more companies are coming to the Medicare Advantage program, and they are offering more plans per company, which means that people have lots and lots of choice, which presents lots and lots of challenges. Here, what I'm really trying to convey is what people on Medicare start to see during an open enrollment period. So each year, Medicare beneficiaries can choose between Medicare Advantage plans and traditional Medicare during the open enrollment period, which runs from October 15th to December 7th. The idea is that people will review their options, think about their needs, think about what's being offered, and choose the plan that makes the most sense. Ideally, they go to the Medicare and You handbook and they go to medicare.gov. But what this visual is trying to communicate is that the public information sources are competing, and maybe not so effectively, with all the marketing materials that people get. When we do focus groups, people say to us that they are swamped with marketing materials during the open enrollment period, and they feel pretty ill-equipped to compare the plans and to figure out what's best for them. These are just Medicare Advantage plans. Keep in mind that people are also getting marketing materials for Part D prescription drug plans. And coincidentally, the typical person on Medicare will have a choice of 28 Part D plans in addition to the 28 Medicare Advantage plans. Choosing between traditional Medicare and Medicare Advantage is a tough one. And most people are making this choice when they first go in Medicare or in the first couple of years right after that. So why choose traditional Medicare? Well, people are actually defaulted in traditional Medicare if they don't choose Medicare Advantage. And the big advantage of traditional Medicare is the broad choice of hospitals and doctors nationwide. There's no provider networks. You can travel to Florida, you can go anywhere, and you can pretty much see any doctor or hospital. There are fewer restrictions, such as prior authorization requirements. For people with supplemental insurance, like a Medigap policy or retiree health or Medicaid, if it wraps around Medicare, they often have almost no cost sharing and very little paperwork. And there's flexibility to switch to Medicare Advantage. But why is Medicare Advantage so attractive? Well, it's one-stop shopping. You don't need to get a separate Medigap policy or a Part D plan. Premiums tend to be lower than Medigap. They often market extra benefits like some dental, vision, gym memberships, and even more coming this year. But there are some constraints, sort of the opposite of traditional Medicare, which is the network restrictions, prior utilization controls, and limited ability to switch to traditional Medicare if in doing so a person would want to purchase a Medigap policy And I'm going to come back to that in a little bit. For people who want to choose among Medicare Advantage plans, that's not easy either because there's so many features to take into account. Provider networks, drug coverage, cost sharing, out-of-pocket limits, deductibles. We're hearing that people focus mainly on premiums, mainly because they're easy to compare. It's one number, and people think it's a good proxy for the value of a plan, but it doesn't necessarily tell them the important things that they need to know, particularly when they get sick. And that's when they are going to need to know whether their plan covers certain cancer hospitals in their area, certain specialists in their area. A few years ago, we looked at provider networks. We found that 1 in 3 Medicare Advantage enrollees were in plans with narrow physician networks. Many plans did not cover local academic hospitals or cancer facilities in their area, but people don't look at those things until they get sick, and that's what makes this just so difficult. One of the attractions of Medicare Advantage plans relative to traditional Medicare is that it has an out-of-pocket limit, and that's required by regulation, not by law, but by regulation. Here also, though, that gets a little bit complicated because the Medicare Advantage plans vary in what their out-of-pocket limits look like. That you can see here, if you just focus on the left side of this slide, plans are required to provide an out-of-pocket limit, and the maximum for in-network is $6,700. So most plans are coming in under the maximum for in-network services, but for out-of-network PPOs, it's considerably higher. So what's kind of interesting but not so transparent to consumers is if they were to be in traditional Medicare and buy a Medigap policy, which is, say, maybe it's $200 a month, they would have much better protection than they might have in a Medicare Advantage plan. But that's awfully hard for consumers to decipher. We did focus groups, and we asked people, do you know there's an open enrollment period? Do you know you should change plans? And people say, yeah, I know I should do it. I get the handbook every year. I use it as a doorstop. I put it in my bottom drawer because it's just so hard. It's so thick, and I just don't understand how to do this. We hear that people feel pretty ill-equipped to make these decisions. So once they sign up for a plan, let's say when they're 65, 66, 67, they not only stick with it, they don't go back and forth between traditional Medicare and Medicare Advantage plans, but they just stick with their plan because they don't really feel that they have the wherewithal to decide whether another plan would be better for them. And that's where this whole marketplace concept sort of breaks down when you think of theory versus practice. In theory, people each year will choose the plan that is best for them. And each year they will review all the plans that are in the marketplace. In practice, people say, I'm too tired for this. This is too complicated. I can't do my drug plans. I can't enter in all that information. I'm going to stay with where I am and hope that things work out well for me. And, the truth is, this is based on personal experience. The people who I've helped have saved literally thousands of dollars. Some of them have saved literally thousands of dollars by making a change. So it's setting up people to make some tough decisions that really do matter financially and maybe for the care that they get. Many people are just not doing it, even though they may do it when they first go on Medicare, when they're kind of all juiced up and ready to make these choices. Earlier, I mentioned this. One of the reasons people may not switch to traditional Medicare is because they may not be able to buy a Medigap policy that supplements Medicare. And I think David and Mark are going to talk a bit more about this. I just want to point out that this is one of the few health insurance products for which there are no guarantee issue protections. So if people don't sign up for a Medigap policy when they first go on Medicare, they may be denied a policy because they have a pre-existing condition in most states throughout the country. And that's a serious issue. And for those of you who are following the drug bill that was just being debated in Congress that passed the House of Representatives, there's a provision in there that would help people who have pre-existing conditions and people who are disabled on Medicare gain access to Medigap policies. finally, I just want to point out that the Medicare Advantage program is growing. The Congressional Budget Office and the actuaries who do these projections have said that within the next decade, the share of people on Medicare who will be in a Medicare Advantage plan will grow from 34% to 47%, so nearly half. Really what that means is Medicare Advantage has become firmly established in the fabric of Medicare. The Medicare of the future is likely to look more like a marketplace with a backup public plan and less like a national health insurance program like people think about it today. And when people are talking about Medicare for all, they may or may not be thinking about this version of Medicare, which has such a prominent role for private plans. And of course, this shift from being a national program to one in which it's more market-based oriented poses lots of issues and challenges for consumers, many of whom have significant health and cognitive needs, which I think my fellow panelists will be talking about. So thanks very much.
Thank you so much, Tricia. We're going to turn to David next. David, what are the trade-offs for consumers trying to decide between plans?
Thank you, Michelle, and thanks to the Center for Health Journalism for having me. I hope to answer that question through the course of walking through the presentation here, which I was invited to in large part because I work for the Center for Medicare Advocacy, where we provide direct representation to beneficiaries, primarily in Connecticut, engage in policy issues and occasionally litigation, and overall work to advance access to comprehensive Medicare and quality health care. The last slide in this presentation has some information about how to sign up for some of our free newsletters and weekly alerts. Today, I'm going to briefly focus on three broad themes from a consumer perspective. Some of this is going to dovetail or reinforce some things that Tricia has just already reviewed and that Mark will cover next. I'm going to talk about the concept of choice versus the complexity that beneficiaries actually face, again, reinforcing something Tricia just spoke about. Spend most of my time talking about your question, Michelle, is the trade-offs about enrolling in Medicare Advantage versus staying in traditional Medicare, with the particular emphasis on barriers to care that Medicare Advantage enrollees often face. Finally, end with a brief policy discussion about a growing imbalance between the traditional Medicare program, sometimes known as Original Medicare, and the Medicare Advantage program. Thinking about the concept of choice, policymakers often hold up the concept of consumer choice as a key pillar of our patchwork health insurance system, including Medicare. Choice of coverage, choice of provider, choice of care is something to be preserved, promoted, and maximized. But health insurance and health care is really one of the most complex issues that we as consumers are expected to engage in, if we even have that option to begin with. The availability, viability, and efficacy of choice start to get somewhat murky the closer you examine it, particularly and including the Medicare program. Tricia talked about the number of plans available to most beneficiaries and some of the decisions that people have to make in weighing their options. But things in Medicare, and particularly with respect to Medicare Advantage, are getting more complex, not less. And a number of recent policy changes have made this more pronounced. Minimum requirements regarding standardization of benefits within a given plan and a given service area have been loosened. And while Medicare Advantage plans can offer a wider array of benefits than they could before, they can now target such benefits to some, but not all, of an individual plan's enrollees based upon a person's health condition, which creates significantly more variables to navigate. Rules that dictate how plans can be marketed and sold have been watered down in recent years to the benefit and convenience of plans, but to the detriment of consumers. And as we'll touch on briefly in a bit, as of late, the government has put its thumbs on the scale in favor of the Medicare Advantage program over traditional Medicare. Could there be such a thing as too much choice? As Tricia noted, consumer behavior suggests there might be, given how few people change plans in a given year. One key takeaway I would like to convey is that informed decision-making is becoming harder to attain, and the system is becoming more tailored to only the savviest consumers. Sticking with the theme of choice, as the second bullet notes, some people don't have a choice. Many people who have some type of retiree coverage through a former employer or a union obtain such coverage through a contracted Medicare Advantage plan. 1 in 5 Medicare Advantage enrollees are in such plans. Similarly, not all choice about coverage options that people have is equal. And as Tricia highlighted, there's an unequal choice or opportunity with respect to purchasing a Medigap plan versus enrolling in Medicare Advantage. With Medicare Advantage, you can get in and out every year, whereas Tricia noted, Medigap enrollment is much more restricted for the most part. The concept of choice is actively promoted when someone is searching for and selecting a plan, but the concept of choice changes somewhat and is actually inverted largely once someone is actually enrolled in a plan. At that point, much decision-making is taken away from individuals regarding who they see and what services they can get. And instead of consumer direction about the care they get, most decision-making is done by the plan. Touching on those consumer trade-offs, when someone has to make a choice about how they wish to access their Medicare coverage, if they have such a choice, there are a number of variables that individuals must weigh. Tricia touched on a number of considerations, so I'd just like to highlight a couple. People have to make some of the most consequential decisions about their coverage when they are first enrolling in Medicare at a time when they have the least experience with it. And as Tricia so effectively highlighted, there are lots of costs and benefits to weigh, but most people default to choosing based upon monthly premiums, of which many Medicare Advantage plans charge zero or a small amount, which also includes Part D coverage. When looking at Medicare Advantage plans, as Tricia noted, there are some pros and cons. Tricia went over some of the pros. I'm going to focus on some of the cons, including the usually restricted network of providers, utilization management, including prior authorization and benefits and costs that can change on an annual basis, including the plan choosing to contract with the Medicare program at all. Now, some people do fine in and prefer Medicare Advantage plans, but those aren't the folks who contact us. As I often say, some people swear by Medicare Advantage plans, other people swear at them. By focusing on consumer problems encountered in Medicare Advantage, I do not mean to suggest that there are not access problems in traditional Medicare. In fact, there are considerable ones, and we as an organization spend the bulk of our time addressing them. But many of such barriers to care are exacerbated by the nature of Medicare Advantage, and the structure of Medicare Advantage creates additional barriers. The next two slides, I'm going to linger on for a few minutes and walk through some examples verbally. The first barrier of care can loosely be called access to services. Coverage, in our experience, with respect to what Medicare Advantage plans will provide, is often less than what someone can get in traditional Medicare. We find in our experience that Medicare Advantage plans often deny or prematurely terminate coverage or care that would otherwise be covered in traditional Medicare. Now, some say this is exactly the point of managed care, to reduce utilization, save money, and hopefully achieve better health outcomes. But from where we sit, we see the real harm that such restrictions cause, including, for example, the inability to attain enough skilled services or therapy so that someone can regain their functionality, or intermittent home health care to keep someone out of an institution, and too frequently, the overriding the expertise of a treating physician with given a respective patient. One example I'd like to highlight is a particularly telling example has to do with so-called per se skilled services. According to the Medicare regulations, if a person is receiving certain types of services in certain settings, like a skilled nursing facility, some services are considered per se qualified skilled services, meaning if they're getting that service, it's generally going to be covered. One example is people who need to use a feeding tube that provides at least a certain amount of caloric intake. Despite such rules like per se skilled services, we routinely encounter Medicare Advantage denials for such services. For example, One Medicare Advantage plan in Massachusetts denied a skilled nursing facility care resident skilled nursing facility care for a resident who had a feeding tube and otherwise met the requirements. The individual retained a private attorney who contacted us for assistance. She appealed through the Medicare appeals process and went all the way up to an administrative law judge hearing. But it was not until the opening moments of the administrative law judge hearing this past September that the Medicare Advantage plan representative stated that the plan has found that her care is medically reasonable and necessary, and they would retroactively cover it. The plan representative noted that the plan had obtained the medical record and the medical director had determined that the care met the skilled definition and was medically necessary. I think I can say, not unreasonably, that that should have been done by the plan at the outset. Another significant barrier to care is the notion of utilization management, tools that most, if not all, Medicare Advantage plans employ that are used to restrict services, ostensibly to make sure that they are medically necessary and appropriate and provided in coordination with other services. However, again, in our experience, inappropriate denials or delays in services occur frequently. One of the materials, the suggested articles accompanying the notice of this webinar included an article by the late Robert Pear, the New York Times, highlighting an Office of Inspector General report that found widespread and persistent problems related to the denials of care and payment in Medicare Advantage. I'm going to walk through an example that touches both on utilization management and then the next topic, provider access. Mr. S was enrolled in a Medicare Advantage plan and had been experiencing involuntary hand tremors, muscle weaknesses and cramping, tripping and balance problems, and occasional slurring of speech, symptoms that over time worsened in intensity and became more frequent. He consulted his primary care physician, who performed routine lab work, but was able to find no definitive answers, and referred him to a neurologist who happened to be in the Medicare Advantage plan's network. Several weeks later, the day prior to his appointment, the neurologist's office called to say that they would have to postpone the appointment because they had not yet received prior authorization from the Medicare Advantage plan. After 3 more weeks, Mr. S finally saw the neurologist, who then said he would order a battery of tests to better understand what was causing his symptoms. After a week, though, the neurologist's office told Mr. S that he had been unable to get through to the Medicare Advantage plan to obtain approval to schedule the testing. Several calls later, this was resolved and the tests were scheduled, except the Medicare Advantage plan did not approve the CT scan the doctor had ordered. Based on the test results, including a delayed CT scan that was finally approved, Mr. S's symptoms and the neurologist's expertise, the neurologist therefore informed Mr. S that he likely had Lou Gehrig's disease, or ALS. But since the neurologist was not a specialist in ALS, he didn't feel qualified to give it a definitive diagnosis. And since no other neurologist in the particular plan's network was a specialist in ALS, Mr. S requested that the Medicare Advantage plan pay for the opinion of such a specialist. The plan denied this request, as it did not consider it medically reasonable and necessary. Our organization intervened with the Medicare Advantage plan on his behalf, along with the neurologist. And after another week of consideration, the Medicare Advantage plan finally agreed to cover Mr. S to go out of network to see a neurologist who specialized in ALS. And this, of course, was all to get a diagnosis. Not only are there delays in authorization, but people can also be caught in limbo with no resolution. Just yesterday, our office fielded a call from a woman with multiple sclerosis in a Medicare Advantage plan who has been trying to get an electric wheelchair from her plan for 12 months. Despite having a doctor's order in hand, despite receiving fitting for the customized wheelchair, she has not received it. And despite repeated attempts to contact the plan, she is always told that her request has not been denied, but instead there's nothing wrong and it was all in process. And meanwhile, she is using her old inadequate chair as she waits. The second major barrier to care that Medicare Advantage enrollees face is access to providers. One of the most important healthcare considerations for an individual is the ability to choose one's own doctor and other healthcare providers. But by design, Medicare Advantage plans contract with a limited network of providers to care for their enrollees. Those that do not cover care outside of a contracted network, those that do cover rather care outside of a contracted network, such as PPOs, charge more in cost sharing for such services. As Tricia noted, we routinely find that the specialists people want and need are not part of the plan's network. And it is difficult to find out what providers actually do contract with a given plan, in part because of the ongoing and consistently poor quality of Medicare Advantage provider directories, essentially lists of providers that are supposed to contract with a particular plan. Even if you have your desired doctor contracting with the plan, there's no guarantee that the plan will retain that doctor. And the plan can even terminate the contract with the doctor mid-year, an issue I think Mark is going to touch on in a moment. We find that even providers come to us to complain, even though we are a consumer advocate organization. And many providers with whom we speak are not happy about contracting with managed care plans, which they complain pay at lower rates, but feel they need to do so from a business standpoint. We are routinely contacted by providers when a plan won't authorize care that the provider is adamant is medically necessary. And sometimes they contact us out of sheer frustration when a provider has actually provided services that were pre-authorized by the plan, but simply cannot get paid by the plan after multiple attempts. And finally, just like to touch on some policy trends. Over the last several years, there have been legislative and regulatory changes that have expanded the Medicare Advantage program, including expansion of coverage of what can be covered in Medicare Advantage, new supplemental benefits, expansion of telehealth, as well as changes in Medicare enrollment periods that favor Medicare Advantage plans, along with changes that restrict Medigap policy. To quote the New England Journal of Medicine article that Tricia co-authored, without much fanfare, Medicare has evolved into a program that provides benefits that are more generous to beneficiaries in Medicare Advantage plans than to their counterparts in traditional Medicare. This has been compounded by the fact that over the last several years, we have witnessed a marked change in the activities of the Medicare program, notably the Centers for Medicare and Medicaid Services. There has been a break from their neutral objective role as a source of information for the Medicare program and has evolved instead into an active role promoting Medicare Advantage enrollment over staying in traditional Medicare. This, of course, is with a backdrop of some pretty significant programmatic concern, including mixed health outcomes of Medicare Advantage enrollees and ongoing payment concerns, including manipulation of risk-adjusted scores. Next slide has a few more resources about some of the issues we talked about. Look forward to the discussion. And just note that Medicare Advantage is really a rich, largely untapped subject for journalists, in which folks can find personal stories and broader policy considerations to discuss.
Thank you so much, David. We're going to turn now to veteran journalist Mark Miller. Mark, what insights can you share from a journalist's perspective and how to report on this evolving story?
Well, thanks, Michelle. Really glad to be here. It's such an important topic, and thank you very much for the invitation. As just by way of very brief introduction, as you mentioned, I'm an independent journalist covering retirement and aging, and I've been doing that for about the last 15 years. I contribute to Reuters, the New York Times, Morningstar, a couple other outlets, and I also do a weekly newsletter and podcast that you can find at my website, which is called retirementrevised.com. Just kind of a brief big picture comment about Medicare in general before I make some comments about Medicare Advantage. Medicare remains really a good deal for consumers. The surveys that you see on consumer satisfaction show a high degree of satisfaction with Medicare, and the average out-of-pocket costs remain pretty reasonable. This is a piece of data from Tricia and her colleagues at Kaiser. In 2016, the average out-of-pocket cost was just short of $5,500, and notably an average of 12% of the enrollee's income. But at the same time, as has been noted by David and Tricia, there's been this evolution of privatization, and from where I sit as a journalist covering this, I think that most of this evolution is driven by ideology of market choice and competition, and also driven, I think, by commercial interests. In other words, the lobbying that the insurance industry is able to do in Washington to make its case and promote it. And as has been noted, this privatization has made enrollment choices more complicated, I think, than they really need to be. And at the same time, I just haven't seen any real evidence that this is producing better health outcomes or lower costs for enrollees or the government. And as Tricia noted, half of enrollees will be an advantage a decade from now, but I want to add that that means half of a exploding Medicare population. So not only will it be half, but it's going to be half, as you can see from this Kaiser chart, of a rapidly growing population as the country gets older. So it's really a good time to be asking this question: does this policy approach make sense for Medicare? We have a history of higher spending or higher reimbursement rates, I should say, in Advantage than we do in traditional Medicare. And I want to back up to the history on this. Under the 2003 federal law that was passed to really put growth of Medicare Advantage into high gear, these plans were given 113% per enrollee in Advantage as compared with traditional Medicare. And the reason was to encourage program growth and provide the running room to add some of these extra benefits that Tricia mentioned. And in 2009, MedPAC, which is the congressional commission that studies the program and reports to Congress, reported that Medicare spending was $14 billion higher due to Advantage outlays. And Part B premiums, were subsequently higher as a result as well, as you can see in the note at the bottom of this slide. And so, Medicare Advantage is managed care, but the pitch here is different than the usual managed care value proposition. The managed care proposition has always been do more with less money. In this case, it's do more with more money. So it's kind of upside down from where I'm sitting. Now, those higher reimbursement rates that I mentioned were repealed under the Affordable Care Act, and that some of you may remember that at the time that the fight was going on over the passage of the ACA, there were these charges from opponents that the ACA was raiding Medicare. The only shred of truth in that was that it was this reduction in these extra reimbursements. So the raid was not on Medicare enrollees or benefits. If it was a raid at all, it was a raid on Medicare Advantage insurance providers. So those higher payments are gone now, but Advantage plans have found other ways to increase their revenue. One appears to be overbilling. In 2016, the Center for Public Integrity documented $70 billion in overbilling over a several years period through, quote, upcoding of patient risk. And we can get into the detail what that means if you like, but I'm providing a link here to the story itself. And just last week, the U.S. Department of Health and Human Services Inspector General came out with a report with similar findings on overbilling of Advantage plans to the Medicare program. Another way that payments can be increased is through kind of gaming of the Medicare bonus point for quality system. It's a system where Advantage plans compete for this 5-star rating for quality. They're awarded bonus payments for higher ratings and quality, but there are ways that system get gamed. And the Wall Street Journal reported that according to JP Morgan Chase, Humana actually generated $600 million in extra revenue in 2018 from this sort of manipulation of the bonus system. So these are all major costs if you think about it against the backdrop of the Medicare program, which is going to have total spending this year of about $750 billion. It's up almost half from 2010. So you think about those overcharges, it's major dollars that we're talking about here. And it also translates into higher costs for the consumer. The standard Part B premium is 31% higher than it was in 2010. And the Medicare trustees say that that the Part B premium is going to rise by 6% annually on average over the next decade. So costs in the program are going up. If we want to find ways to save money in the program, Medicare Advantage is certainly one area that I think can stand some scrutiny. Now, let me just pivot here and talk a little bit more broadly about Medicare in the context of retirement planning, since as I told you, I cover retirement broadly, not just healthcare. So I think about Medicare in this broader context. And I just want to comment that these choices that are made around Medicare enrollment are among the most important retirement decisions that we all make. The transition that people make from employer coverage or from the individual market into Medicare is really fraught with potential penalties and coverage gaps. So not only are the choices complex in the way that Tricia and David were outlining, but just thinking about it from the standpoint of when you retire, there's a whole lot going on here. Medicare requires people to sign up during a limited window before and after their 65th birthday. And if you don't do that, you are socked with some very stiff late enrollment penalties that continue lifetime, and also some potentially expensive long waits for your coverage to start. The one exception to that deadline that I mentioned is if you're still working at age 65. In that situation, you can delay your enrollment without incurring penalties. But for everyone else, it's an important deadline. The penalty is really stiff. It's 10% of the standard Part B premium for each 12 months you're late, and that penalty persists lifetime. It's not just a one-time thing. So you run the numbers on that, you see it can be significant. And if you're late, if you miss your window to enroll, you could be facing a coverage gap as long as 18 months due to the way that the calendar works with various enrollment periods that you would need to take advantage of. So at that point, when people are first enrolling at 65, Medicare Advantage can be pretty appealing for younger and healthier people. You know, it's got all these extra benefits that were mentioned earlier, such as, you know, built-in prescription drug coverage at no extra charge, dental and vision and the like. So, you know, it sounds like a pretty good thing. But there's this really important point that was mentioned by Tricia, that if you forego traditional Medicare at this initial enrollment point, you have forfeited your right to buy Medigap with no medical underwriting for pre-existing conditions. And this is a huge deal, because if you ever want to move into traditional Medicare, you are going to want a Medigap plan, because what Medigap does is puts a cap on out-of-pocket costs and, you know, keeps your overall cost predictable and reasonable. So traditional Medigap care without Medigap is something that's not going to be desirable. So, and this is a point that I think a lot of people miss at this initial point of enrollment. It's a huge deal because at older ages, when maybe you're less healthy, you know, major health problems are more likely. There's no doubt in my mind that traditional Medicare with a Medigap and Part D plan is the gold standard of coverage. It takes most or all of the out-of-pocket costs off the table, and it provides access to nearly all U.S. health providers. And I can't think of any other form of health insurance in the United States that does that at this point. People drop out of Advantage plans for some of the reasons that David was discussing. I'm not going to go into those here for time reasons, since he's going to do it in great detail. But these restrictions on access to health providers is one key reason that I hear that people leave, and the inappropriate denial of claims are another big issue. Some story ideas I want to share with other journalists on the call. First, some ideas in terms of just kind of consumer and policy story ideas. One, it's worth pointing out that traditional Medicare is still 2/3 of the market, and it should be portrayed as it is the default choice, as Tricia mentioned, you're defaulted into it. But, you know, it often feels to me like the coverage is the other way around. There's so much focus on plans and plan choice. And I think that given the all the money that's spent on marketing of these programs, journalists can and should play a bigger role educating the public about this choice. I think journalists could do more to explain Medicare to the public, how it's funded, for example. You know, we routinely hear politicians talking about the idea that Medicare is going bankrupt or that it's running out of money. And that frankly is just gaslighting. Federal programs like Medicare cannot go bankrupt by definition. And the funding of Medicare is somewhat complicated. There's a trust fund that finances the Part A program, which is hospitalization. But everything else is sort of pay as you go, in the sense that the trust fund revenues come from the payroll taxes we all pay throughout our working lives. But Part B, Part D, those are paid through a combination of premiums and general government revenue as we go. So, costs can go up, and they are going up significantly, but the scare tactics of charging the programs going bankrupt need to be vetted and explained and put into context. Another good story, I think, I do it every fall, is to explain to people the importance of shopping your coverage regularly after the initial point of enrollment. Tricia mentioned that she has been able to help people save thousands of dollars herself, and I hear that routinely from people who provide counseling on Medicare, that there's a fall enrollment period where people can reevaluate their coverage and make changes in their drug coverage, or move back and forth between traditional Medicare and Medicare Advantage. And also, journalists can provide a real service, I think, by helping the public understand where they can go to get help with plan selection. And I'll say more about that in a minute. Some story ideas that I think would be interesting at the local or regional level. I would love to see some investigative work on the local market Advantage plan directories. It's been documented that the directories that plans publish of what doctors and hospitals are in their network are full of errors, and they're outdated frequently. The big providers will admit this. And I think it would be interesting to actually try to quantify that. Take a look at the directories and then go check them against the providers, and run some stories pointing out what's going on with these directories. I think this story about the denial of claims could easily be localized with human interest angles. The network provider instability point, I think needs to be. I think it needs to be covered better and in more depth. Not only do you have this issue of problems figuring out whether your doctor is in the network you're considering, but Advantage plans can drop providers out of the network at any time. So you could be in the middle of your plan year and suddenly your doctor is no longer available to you. There's a pretty high-profile poster child case of this in 2013, where United Healthcare dropped thousands of providers out of its network without notice, including Yale New Haven Hospital. There was such an uproar over that Medicare had to respond by creating a new special enrollment opportunity when significant changes are made in the plan provider networks. So again, I think this is a point that could be explicated at the local level. Human interest angles, I think there could be interesting stories to do profiling patients who have had issues with networks, the varying experiences people have obtaining care for chronic conditions in the traditional program versus Advantage. Where to go for help? I mentioned earlier, there's these things called the State Health Insurance Assistance Program, or SHIP for short. There's one of these things in every state in the country. These are places where people can go for free, unbiased help with plan selection. And just about everybody I talk to who has expertise in plan selection says that things are just so complicated that people ought to get help. And SHIPs are a great place to get them. There's public funding, and it's a network of volunteer trained counselors. Interestingly, the federal funding for the SHIP program has been threatened repeatedly, but it does continue to roll on. It's kind of a well-kept secret. I'm providing a link here to where you can find the SHIP in your state. They are also great resources for story ideas. I interviewed directors of SHIPs around the country on different stories. They really have their fingers on the pulse of what's going on in the program nationally, but they can also tell you about what they're seeing on the ground in your local market. And then customer service problems. There's a couple of things I'll mention here. Medicare rolled out a new version of its online plan finder this fall, just before the fall enrollment period started, and it's been plagued with all kinds of problems and errors. And if you contact and just discuss this with your local SHIP, you will hear about this, because the counselors are going nuts with this. But it's a good current hook, if you will, for getting into a story about the complexity of shopping for plans, and now this additional headache of problems with the new plan finder. And then just to briefly mention, so the Social Security Administration is how a lot of people interact with Medicare when they need to make changes on their paperwork and whatnot. And I wrote a story recently, the link is at the bottom of this slide, for the New York Times, about this burgeoning customer service crisis, really, at the Social Security Administration, which is the result of years and years of budget cuts. The the Social Security Administration has been forced to close 67 field offices around the country. There are huge backups in there for waiting times for people waiting for help on their toll-free line, and their payment processing centers, which is sort of the back office paperwork. That last point's important for Medicare, because when changes in Medicare coverage go through, they go to these payment processing centers, and I've heard some horror stories about people waiting for a year or more for errors to be fixed in their coverage. And last, a financial story idea, if there are business and financial reporters on the call, and that's the background I come out of. I think there's a great story out there waiting to be done by somebody about the Medicare Advantage profit machine. There's a handful of companies that are leaders in this business that are building enormous businesses on Medicare Advantage. And so a story looking at the revenue flows to the biggest players, impact on their corporate growth and their stock prices would be really interesting, framed with the question, is this how we want our taxpayer dollars spent? So I'll stop with that, and maybe we can field some questions and comments.
Great. Thank you, Mark, and thank you for all of our panelists. We're going to have some time for a few questions now. I'm going to start out with a question by Karen Handmaker, who says, would some of the experiences David describes regarding denials and delays happen in traditional Medicare? In other words, would the patient have received his tests and specialist visits to diagnose his ALS in traditional Medicare?
This is David. Thank you for the question. It's our guess that it would have happened a lot sooner, assuming you get an appointment with the requisite specialist. In this case, the appointments were made and the plan hadn't authorized, the visit or the tests at the time of the appointment, and it was a continual battle to get authorization each step of the way. So assuming you can find a provider who is able to take you more quickly, it's then in traditional Medicare, the provider's judgment as to whether or not he or she thinks that a service, can and should be provided by Medicare, and they'll go ahead and provide that service. So that's an example of additional barriers to those utilization management techniques in Medicare Advantage that we feel disadvantage enrollees much of the time.
We have a question from Christopher Snowbeck, who says, David is providing a number of very important examples of barriers to care with Medicare Advantage plans. Is there a way for consumers to evaluate whether MA plans from particular carriers are more or less likely to create barriers to care, or are these problems equally likely across all MA carriers?
I'll take a stab at that one too. Thanks for the question, Chris. The Centers for Medicare and Medicaid Services is tasked with oversight of Medicare Advantage plans. And part of that oversight includes conducting audits of plans to see whether or not they're complying with some of the basic requirements, including, providing necessary services, honoring appeal rights, et cetera. And the regulator does sometimes issue punitive action and compliance plans. But unless the public is scouring those audits, which usually occur after the fact, they're largely not going to be exposed to such information, in part because some of the quality measures, and Mark touched on the quality bonus payments that go to Medicare Advantage plans. There's star ratings for plans, 5 stars, highest plans that earn 4 or 5 stars, get quality bonus payments from the plans, but those audit findings that often uncover these types of issues do not factor into those quality ratings. So we've had instances where a plan will appear to the consumers as being a 4 or 5 star plan, yet just recently has been cited for some of these very deficiencies that give rise to such concerns about access to care.
This is Tricia. I'll just say that it's very difficult for even researchers to get good information about denial rates and for what reason by plan or by insurer, because the information is not available to researchers. So it's really not available to the public, and it would be very hard for the public to go to the Medicare plan. It would be impossible for someone in the public to go to the Medicare plan finder and try to understand, which plan, which company is more or less likely to deny claims or impose certain restrictions than others. They can find out about certain prior authorization requirements. That's publicly available. But in terms of claims denials, the information is pretty batched up, so you don't really understand why claims are being denied. It's virtually impossible to get that information.
This is Mark. I'll just add quickly that, thinking back to Tricia's point about the lack of interest most people have in shopping at all for these plans and doing the homework, getting to this level of detail seems, very unlikely, even if people wanted to do it and could get at the information.
I think people really want to have the information. They really want to make good choices, but they feel daunted. They just feel that there's either too much information or not enough clear information, and so they're stymied in the process.
Yes.
And we have a question from Gary Schweitzer, who says, do you have data on the number of Medicare fraud, waste, and abuse appeals from Medicare Advantage enrollees versus from traditional Medicare and supplement enrollees?
This is Tricia, and I'll just give an easy no.
And we have a question from Kenneth Pulse. Do Medicare Advantage plans pay providers less compared to traditional Medicare for the same care?
You want me to take that one?
Sure, I'll add to it if it's okay.
Okay. Well, what I was going to say is this is a great area to dig into. There has been some work done by researchers and CBO, and they have found that for certain services, Medicare Advantage plans tend to pay on average about the same as traditional Medicare, but I suspect there's a lot of variation, and I'd be very curious to see how that differs for certain types of providers, like post-acute providers, like home health providers, skilled nursing facilities, because what I've heard anecdotally is that plans are paying less than traditional Medicare, and that's been a concern, but I haven't seen good backup analysis.
And this is David. I would just add that anecdotally, the providers we speak with also tell us that Medicare Advantage plans tend to pay less for the same services. And just as an additional point, the Medicare program does not really regulate the relationship between Medicare Advantage plans and their providers, their contracted providers. It sees that as just a plan issue. So in a lot of ways, Medicare has nothing to do with how much the plan turns around and pays the providers itself. And that's really between the contractual relationship between providers and plans.
This is Mark. Just to add a quick comment, I think an interesting local market story or regional story would be to talk to healthcare providers and get their views on Medicare Advantage, both generally and the specific plans in the market, if you can get them to talk about it on the record, not only from the standpoint of what they're getting paid, but how they think about these plans from the standpoint of the ease of working with them to get healthcare services to patients and the paperwork and so on.
I mean, they would be interested in issues like prompt payment, how quickly they get paid by plans, with the hassle factor, whether or not from their perspective, they're getting denied more than traditional Medicare, and whether or not they have difficulty negotiating contracts with plans so that they may or may not be in the network. And this might be an issue that comes up more with certain types of providers than others.
We have a question from Cheryl Clark, who says, I've polled many of my contacts, including my physicians, who are between the ages 65 and 70 who are in Medicare Advantage plans, and none of them know that they won't be able to get out of them and buy a Medigap plan if they develop a condition or illness that would exclude them. Are there any efforts to require brokers and Medicare Advantage plans to tell enrollees about these limitations if they should develop what a Medigap plan considers a pre-existing condition? And if not, should there be?
Well, without addressing that question specifically, one of the things we have pushed for a long time is better notice to Medicare beneficiaries about the different pitfalls that they face, including the fact that people, as articulated by Mark and Tricia during the presentation, do not have the same rights to enroll in Medigap plans as they do to enroll in Medicare Advantage on an annual basis. We're all for better notification. But as even better, as Tricia mentioned, the HR 3, the bill that passed the House last week, would actually improve rights to purchase Medigap plans and would expand better enrollment rights to a larger group of people. And that's really the thrust that we're behind.
And I just add that, I think an interesting local story would be, it was mentioned that there were 4 states that have, added these additional guaranteed issue protections. A good question around the country at the state or local level or the state level is, why isn't that happening in my state? Is anybody trying to push to add those protections? You could ask, the state level medical society whether that wouldn't be a good thing.
This is just a great local story. The issue came to my attention from a friend who had a biking accident, and he went to the emergency room and he was fine because of the accident, but they found a tumor in the back of his neck and he needed to see a specialized surgeon, and that surgeon wasn't in his plan. And he called me and I said, well, just switch to traditional Medicare. And he said, I can't because I've already been denied a Medigap policy because I need surgery. So I think if you can find people to sort of convey how this issue plays out for real people, it would be very useful. And a whole group of people who are not protected are people who come onto Medicare who have a permanent disability, who don't have the same rights that people who turn 65 have when it comes to buying a Medigap policy. The drug law that just passed would provide an open enrollment period for people who come on to Medicare because of a disability, and there are about 10 million people right now who fit this category, but they're really locked out of Medigap in many states. So that would also be an interesting story to tell.
And Tricia, isn't it the case, didn't Kaiser do some research on the issue of availability of providers in Advantage plans in local markets and found that in many cases, the top medical center in a given region is not in, a high percentage of these plans. So in that situation, like your friend, where you want to see the top specialist in town on whatever your issue is, you may be out of luck if that person's not in your network.
Yeah, that's absolutely true. We looked at academic medical centers, we looked at NCI-approved cancer centers, and found a lot of variation across plans. I don't have the numbers in front of me, but I want to say 1 in 5 Medicare Advantage plans did not have an NCI, a National Cancer Institute affiliated hospital in their network when there was one in the area. So for people who find out in the middle of the year that they have a serious condition like cancer and they want to see a certain specialist, they really could be out of luck. And many people don't want to go to traditional Medicare without a supplement because they don't want to be financially exposed, because Medicare does not have an out-of-pocket limit. And that's, Medicare's got a lot going for it, but that is a limitation for people if they can't get a supplement.
We're going to just shoot 2 more questions your way. One from Caitlin Swanner, who says, what is driving government interest in Medicare Advantage? Presumably it helps control healthcare spending.
I'll go a little bit on this one. I mean, there has been a lot of interest in promoting choice, both in ACA marketplaces and for people on Medicare. And this administration, but also prior administrations, have promoted the idea of creating choice in the marketplace. I think it is in some ways a philosophical issue, because there are people who prefer the idea of a marketplace to a government-administered program. They're people who believe that market competition can drive down costs. And so it's sort of, I think, the push for Medicare Advantage today is sort of founded on both the belief that the private marketplace can deliver better, whether that's right or wrong, I'm not saying, and that some are concerned about having a large government-administered program, even one like Medicare that's hugely successful.
And I'll just add, I think that the ideology or philosophy may be the foot forward, but I think there's an enormous business story here too, which has to do with, frankly, just the amount of money sloshing around in Washington, lobbying money. As I mentioned, the health insurance industry is building an enormous Medicare Advantage business. They have a lot at stake, and so there's constantly a push to do more with it. And it's just a business. It's a business story.
And I will say, the more, with Medicare Advantage plans operating profitably, we think they're operating profitably because they keep coming. There are more and more plans, insurers coming into this market, and with Medicare Advantage moving across the country and growing in markets that previously didn't have much of a managed care presence, more and more members of Congress are going to have constituents who like their extra benefits and want Medicare Advantage to be sustained and have plans operate profitably so that they can stay in the market and keep offering them extra benefits, which people like.
So our final question is from Susan Jaffe, who asks, are providers allowed to disclose what they are paid under their contracts with insurance companies? Isn't that confidential business information?
As the resident lawyer on the panel, I'll venture to guess that might be spelled out in the actual contract between the provider and the Medicare Advantage plan itself. There might be clauses in there that say this is proprietary and you cannot disclose this amount. Absent that, the providers might have some disincentive of disclosing such information for purpose of maintaining good relations with the plan. But if they're willing to disclose it and they're not prohibited from doing so, that would be, I'm sure, very interesting to other providers in the given area.
With that, we're going to end our webinar. I want to thank our panelists for their really helpful insights and our audience for their great questions. Just a reminder that we'll be sending everybody a quick survey after this where we ask you about these presentations as well as your ideas for future ones. Please take a moment to fill that out. And we'll be archiving this webinar later today with all the PowerPoint presentations at centerforhealthjournalism.org. Thank you so much and happy holidays.